Hello, everyone, and welcome to the Bayesian Musings podcast. I'm your host, Vishnu. Today's episode is with Dr. Ruby Wyatt, a palliative care physician who is completing her GenMed training to become a dual-trained specialist. Ruby was working with me recently in the ICU as a registrar as part of her GenMed requirements, and throughout the podcast, you'll hear me trying to recruit her into a third specialty. I've known Ruby since 2020, since the days in which I was starting this podcast stuff, albeit not to the wide world, having not published this until recently. She was doing MedReg nights during my short stint as a MedReg admitting job. I'll be honest, it was probably the hardest rotation I've ever done and certainly eye-opening. I was always grateful for the support from Ruby, her calm nature and her knowledge. Things that frustrated me or decisions and uncertainties I struggled with, she was unfazed by and had a clear answer for. And what a unique perspective to hear from a palliative care physician, especially with a recent experience in ICU. I certainly had great insight and great support from her during the ICU rotation, and her knowledge was certainly very useful and provided a very mature perspective on many issues in the ICU. I was curious to hear about her perspectives, not only in the ICU, but also into palliative care and compare it with my brief experiences in palcare. I really appreciate her making the time to do this, and I hope you enjoy the listen. Here we go. Good luck to both of us.
Exactly.
So I think what I'll do is put in an intro and talk great things about you and your accomplishments and qualifications and all the other letters after your name.
0.
You have MBBS, don't you? Oh, no, MD.
MD.
Yeah. The inferior of the Melbourne Uni courses, as I might say, given that you went to Melbourne Uni.
Yeah.
Although it's given them lots of money now, I'm sure, and
Yeah.
I probably should be careful what I say. This is going to be in public. I'm going to get a hitman after me from Melbourne Uni. I still get emails from them as alumni. I delete them.
For cash. That's all they want.
Oh, is it?
Donations.
I don't read it. Okay, so Ruby, just fresh off an ICU rotation, which you loved and is going to change from palliative care to intensive care training, as I'm sure.
Yep.
Convinced, definitely going to happen. And now suffering in GenMed land.
Yep.
So, firstly, thank you for agreeing to doing this.
Thanks for having me.
And after 3 years, I've dusted off this stuff and ready to go again. So, do you want to just... I don't know a lot about your personal life, and you don't need to tell me too much, but just a bit about, I guess, where'd you grow up? You're from Geelong, I know that.
Yeah.
I do know that now,
Yeah.
from going out for reg drinks.
Yeah.
So, want to tell me a little bit about...
Yeah, so I grew up in Geelong and have spent the majority of my adult life here as well. I've got a pretty small family unit and we're pretty close, so hoping to remain in Geelong long term. I've got pretty strong community ties to Geelong as well. I've done a lot of surf life saving and community work, volunteering and that sort of stuff. So hoping to continue all that as well where possible.
Yeah. What was it like growing up in Geelong?
It was good. It used to be a lot quieter.
Yeah. Well, I was telling someone this recently because when I lived here by myself, I lived across the road and it was a 3-minute walk door to door to work. And now I have to drive for 15 minutes and it feels like I'm in Melbourne.
Yeah. All those roadworks and traffic lights.
Yes.
Yeah.
And the construction.
Yep.
May as well be in Melbourne.
Yep. I remember when that road used to be 100 kilometres an hour too. It's no...
Is it not? I mean, whoops, I don't drive that an hour. Yeah. And it's not I think the other one to Clifton Springs is 100 for most of it, but this one isn't until past here, unfortunately.
Mm-hmm.
And then when you went to Melbourne Uni?
Yep.
How was that like leaving Geelong?
Yeah, it was okay. So it was nice to get some independence and that sort of thing. And I lived on campus for the first year and made some connections through Queen's College, and then moved off campus and with some mates, and then had to move to because I was part of the rural clinical school for medicine, so moved out.
Where was that?
I went to Shepparton first, and then bit all over for the third year. Was kind of bit of Echuca, Wangaratta and Ballarat as well.
Yeah. I think we talked about this because I was an internship and you would have probably been there.
Yeah, probably.
Yeah.
Yeah.
So, but you did undergrad in Melbourne Uni as well?
No, I did undergrad at Deakin.
Right.
Yep.
So you were still in Geelong for that bit. And
Yeah, that's right. Yeah.
Yeah.
Yep.
And how did medicine happen for you?
It was a bit of, I just kind of fell into it. So I did the
As one
right
does.
subjects. Yeah.
Yeah.
That's right.
I was just a genius and...
No. I did the right subjects in the right undergrad course, and then I did my honours in developmental biology, and my honours project supervisor was the head of Deakin Medical School. And we were talking about setting myself up for a PhD project and had the title and everything, and the application was in.
Mm-hmm.
And then he said, "Why are you doing this? There's no job security in research. You should be doing medicine." And so I was like, "Oh, okay, I'll put my application in for medicine," and got in.
Right.
And then found there's no job security in medicine either. So, yeah.
Which you find out when you're about to finish.
Yeah, that's right. Yeah.
Interesting. Okay. And now you're not... But research-wise, didn't ever want to go back to it?
I've thought about it. I've, when you contemplate pre-exams, post-exams, your career choices, I definitely thought about doing a little bit more research, and have done the trainee project and that sort of thing. But I think I find the writing of the paper difficult.
Yeah.
Yeah.
So given that you went into med school without planning on it, how was that like?
It was pretty tough, to be honest. I think my recommendation would be, if you don't have a passion for it and a drive for an outcome at the end, that it's actually really challenging. It's really hard to push yourself through those exams and study for something where you're not really sure what the outcome's going to be at the end. Yeah.
How'd you get through it?
Great study groups and great friends that kind of pull you through. And then I had a vague idea that I might want to do something more physician-minded, so that helped direct which exams to do.
In med school?
No, I guess that's more in like junior medicine, yeah.
But I guess in med school, so I asked this as someone who didn't want to do medicine either and struggled through med school. How did you get through it? Or how did you find the transition from like having done an undergrad uni course into the MD land where there's lots of people that are doing this because they want to do it?
I found it hard. There's a lot of high achievers, a lot of people who are very intense in how they study and how they compete with you. And I found it very challenging to interact with those personalities. But I think over time, particularly with going to the rural clinical school, you kind of find a little niche group of people who are more aligned with your views, and I have a pretty laid back approach to study. So it was once I found those people, it was a bit easier.
Yeah. Did you have other challenges in med school, did you find, or?
I found it hard to move away from the ocean, like having grown up near the ocean and not being near water was really a weird experience for me. So being quite inland at Shepparton and that.
They have a lake?
Man-made lake, yes. Yeah. And a river.
Is there? Where's the river?
The Goulburn River runs through.
I can't even remember where it was.
Off to the west a little bit, yeah.
I don't think I ever went. I do vaguely remember the lake and going to a gym once or twice.
Yeah, the highlight of Shepparton, the gym.
Yeah, and I went in one day and was like, "Can I cancel my membership now, please?" Because I haven't used it.
Yeah.
Yeah, okay. And where did you intern? Was it all been Geelong since? Or?
No, so I did my internship and my BPT1 at Ballarat Health Service.
Yeah.
It's called something Grampian Health now, isn't it? Something like that.
Right.
Yeah. That was really good. It's the size is secondary hospital, so a bit smaller than Geelong, and it had quite a good feel. Like everyone sort of knew you and helped you, and and that sort of thing. They were very supportive of paying you overtime and making sure you got your teaching, and it was quite good as an intern. Yep.
Did you do any Melbourne time as in Melbourne hospitals? It's part of med school, like before clinical time.
Yeah, some Royal Melbourne time, very short amount. Yep.
Yeah. And you went back there later on, didn't you?
I went. Yeah, I did a 6-month stint in Royal Melbourne and Peter Mac.
Yeah, we'll get to that, and definitely not a topic that you don't know what I'm going to talk about, do you? Okay, and then Geelong, like third year onwards, was it?
Yeah, pretty much, and then the occasional kind of 6 month through training at various hospitals, just when you have to. Yeah.
So BPT, like pretty much from second year onwards, was it?
Yeah, that's right.
How did that come out?
So you can't stay at Ballarat for BPT. You have to do at least 1 year at a tertiary hospital or quaternary centre. And there's strong ties, or there used to be strong ties with Ballarat and Geelong. So it was kind of an easy pathway to kind of transition to that hospital. And it was where I wanted to be anyway, because I wanted to move closer to family again.
Yeah.
Yep.
You mentioned that you were drawn to the physician things even throughout med school. Was there anything that you remember as to why that was the case?
It was really evident when I did my surgical rotation as an intern. And my favourite thing was you were left to your own devices and you became the med reg of the surgical ward. And you were managing everything yourself. And that really was where I was like, oh, I don't want to go sit in the theatre and hold a retractor. I want to actually talk to the patients and help improve how they're feeling. Yeah.
What about ED?
I didn't like ED. I found it a very hectic environment and more like you were just being asked to triage which team this person needed to go to rather than
didn't
actually,
have the time that you wanted to.
Yeah.
Yeah. I felt similar because when my intern year, ED was my favourite because I kind of felt like I had a bit of autonomy. I could make some decisions. One thing when I was an intern though, I wanted to do orthopedics or psychiatry.
I can't imagine you as an ortho bro.
Well, yeah, neither could they apparently. But it was, I guess, like the team was very friendly, and I got along with the trainee, the registrars on that rotation, and my co-intern was fun.
Yeah.
At my end of term feedback from one of the director, he was like, "So I hear you want to do orthopedics?" I was like, "Yeah." He was like, "Well, I've never seen you in theatre." I was like, "Yeah, about that." Forgot they have to do that bit of the training.
Yeah, it's the least favourite part of orthopedics.
Yeah. I think I only like ortho because I have a lot of family friends that are orthopedic surgeons, and I've broken my arm a couple of times, so I like shoulders, but nothing else, which didn't bode well for ortho training for me. And so I worked with you when you were a physician trainee.
Yes.
And back then you wanted to be a hematologist.
Yeah. Yeah. I still am drawn to oncology, more medical oncology. I think it first started, I did a resident term in Ballarat. They have a combined med-onc-hem-onc unit. And I was really drawn to the type of medicine it is. It's quite like they do try and make it fairly holistic, and there's lots of multidisciplinary meetings and interactions between the specialties, including palliative care and surgeons and radiation oncologists. So I liked that part. I also liked the research behind it, like the actual science, and having things to kind of guide you. I find that helps with my anxiety about decision making in medicine. And I really liked interacting with pal care during that term, and so I thought I still wanted to kind of go into that oncology space when I was doing my physician exams.
Yeah. So I would have worked with you after your exams, wouldn't I? 2020?
2020, we were still kind of mid the clinical, because it got delayed because of COVID.
Yeah. And were you thinking sort of along the lines of the research aspect of HEMONC or whatever training and bringing back those pre-med school day aspirations, or?
Yeah, I think I got really burnt out during COVID and trying to sit the clinical exams during COVID.
That year that nothing went wrong with the IT system of the physician college.
Yeah, that's right. I think because of the exams got delayed and you had to do a provisional first year, I decided not to apply for any oncology program.
Say that again, sorry. First year is in...
So because we had to only pass part of our exam when jobs were needed to be decided upon, you had to apply for provisional advanced training. And and if you didn't pass your second part, then that year didn't count, basically.
Right.
Yeah. And so I decided not to apply while I was so stressed and that sort of thing, and ended up just doing a Gen Med advanced training year, part of which I did 6 months of palliative care, and that really changed everything for me. Yeah.
You and me both.
Yeah.
Yeah. Okay. With the physician training, right, before we get to the pal care bit, that getting onto the pathway pretty straightforward, is it? Or how does...
Yeah, so you just you get a basic physician training job, and then you apply to the college. There's no kind of entrance.
So it's all past the exam, and then you go for your specialty training.
Yeah, so the exam's kind of the big hurdle.
Yeah. And is it interviews based after that for your particular specialty that you apply for?
The advanced training, Yep. So I guess palliative is an unusual specialty. So there's two pathways onto palliative care training. You've got the physician's pathway, which you pass your basic physician training and then apply to the centralised match. And then you can also become a GP, letter as a GP, and then apply to the centralised match as well.
Mm. Yep. And how long's the training for palcare?
3 years, full time.
After your physician, so it's still like an advanced trainee post physician basic BPT exam.
Yeah, so 3 years BPT, 3 years advanced training. Yep.
3 years BPT?
Yep.
Okay, because I thought you could do your exam like PGY3, is that not?
Yeah, so you sit the written at the start of your third year, in the February of the third year.
Third year of BPT?
Yeah.
Oh, okay, so not PGY3, so because intern BPT1 is PGY2, isn't it?
Yeah.
Okay, and then so you have to do another year before you can set exams?
Yep.
Right, okay. I didn't know that because I thought people just sat when they're like third year residents and being registrars.
Yeah, no.
Yeah, okay.
Yep.
And then 3 years as palcare training.
Yep.
Did you do that all here or did you go elsewhere?
No, I've done a lot in Geelong. I've done 6 months at Ballarat and then 6 months at Peter Mac and 6 months at Mercy as well.
All palliative care?
Yeah.
So what was it in that 6 months of palcare rotation that you did that changed your life?
A lot of it was the team, and it made me realise how much I loved working with the team in Ballarat as well when I did that HEMONC MEDONC job.
Yeah.
I think palcare draws a certain type of person to that specialty, both nurses, allied health, doctors, everyone. And they're so good at working together as a team. But also the type of medicine as well, like being able to spend time with someone, getting to know them and what's really important to them, and then being able to advocate for that with other teams who don't have the time to do what you've been able to do. Yeah.
Yeah. Can you expand on the special kind of person that gets attracted?
I think...
Just talk yourself up, you know.
I'm still not sure if I'm the most suited to it, but I think...
to, what do you mean? To palcare?
Yeah.
Can't say that, you're a consultant.
I'm definitely down the road now. I don't know if there's any turning back.
I think you'd make a great palcare consultant.
I think,
I can see why you didn't do surgical training. It's
yeah, I couldn't do that. I think the Palcare team, really, it's a lot about like listening and being curious and having the patience to explore, and being able to be compassionate about what you hear as well. And because there's some things that you learn about people that you thought you would never learn about another human, to be honest. Some things come out by the end of life that you, it's very interesting. Yeah. Can be very interesting.
I mean, so teamwork, collaboration, patience, curiosity, and navigating through difficult, challenging interactions with other humans. Sounds a lot like intensive care medicine to me.
It's not dissimilar at times, so you're right. Just a different end goal.
Well, sometimes.
Sometimes, yeah, that's right.
Yeah. Okay. Okay. And how is the difference between working places like Ballarat and Geelong compared to your time in Melbourne?
You're very much, I felt like I was very much a number when I worked in the PMAC system.
Okay.
Like I didn't know anyone. Or like you walk around the halls and no one says hi to you. Whereas like when I worked in Ballarat, like this CMO would walk past and be like, "Hi, Ruby, how's your surge term going?" Like they actually knew who you were and what you were doing. It was amazing to see the amount of resources that the quaternary centres seem to have in comparison to other hospitals as well. Certainly a lot easier to get procedures up there than it is anywhere else that I've worked. Yeah.
So, and what about like the teamwork and interactions with other specialties and?
Yeah, so I think it's very similar to other hospitals. There quite a lot of multidisciplinary meetings and discussions about patients. A lot of online messaging with the
Epic.
Yep. You just get all these random messages from surgeons being like, "They're in pain still," and you're like, "Okay, I'll work on it." So that having an Epic was definitely made it a lot easier to interact with the various members of the team. They seem to have a lot of access to community-based rehab and psychology and that sort of stuff that doesn't seem to be readily available at other places. It's they do have a really good team, and they seem to interact with the community programs quite well, despite them not being directly kind of associated with the PNMAC hospital. Yep.
And they're the things that attract you to like the Hem-Onc services and Palcare in Ballarat. Was that still the same thing in that centre, or did it feel did the difference between like a rural versus city thing play more of a role?
Yeah, it was almost like next level at PNMAC. Like like they were doing studies into like the genetics behind how people absorb opioids and things like that.
Yeah.
Like just much more like in-depth research and that sort of stuff. They're supposed to got a lot more funding, so that makes it easier. So I think it's similar, but like definitely next level. Yeah.
And even the interaction between the teams and things, was it still just as I guess if I ask the question differently, do you think if your exposure to that was at Peter Mac or in a city centre, do you think it would have been a different impact on you compared to what you had at Ballarat?
I think it was similar. I think there was still that kind of, even maybe more so, that willingness to kind of do more. So, for example, like they had their multidisciplinary pain meeting, and it was constantly, what can we do? What can we do? It was not, oh, okay, that person's they're done. Like,
Yeah.
there was none of that. It was constantly trying to explore what more can be done, which I really like that kind of, even if it's not something that's actually like an intervention, just at least been asking that question and making sure that person's not being forgotten about or just discounted.
Yeah. Okay. So it sounds like it's you probably would have gone down the same training pathway one way or the other, regardless of where you were working or how you got initially exposed to it.
Yeah, I think so. I think I'm just attracted to that type of team that exists. Yeah.
Well, that's interesting because I guess I feel like there's, as you say, there's a difference between rural medicine or regional medicine versus the city, at least with the amount of resources that you have, and whether that changes how each specialty or department runs. I certainly find there's differences in the way ICUs practice between different centres, but that's different between city units as well. So it did, I guess, partly seem resource dependent to some degree. But that's interesting. So awkward pause. So that's, I guess, so you talked about your PALCare thing, and now you're done.
Yeah, completed the PALCare training, which is great.
Consultant time.
Yeah, I just want to go back.
When did you finish your PALCare?
Last year.
Okay. And now you're doing ICU training after 6 months in ICU? No. Okay. I can dream. I think you're excellent in ICU. I think you should do ICU. But Gen Med?
Yes. Yeah, so at the end of my palliative care training, I decided I wasn't willing or didn't want to move away from the Geelong region for work. I didn't want to prioritise that in my life, and so have decided to return to Gen Med to dual train to increase my employability, basically.
Yeah. How do you feel about that?
Yeah, it's been challenging. Yeah, I forgot how it is in Gen Med. Yeah.
Well, you've had 6 months in ICU, so that would have been fun and exciting, and
yeah, it had its own set of challenges. Yeah, but yeah.
So how much longer do you have to do?
So just 6 more months after.
And then you're okay. So you're double consultant after the end of this year.
Yeah.
Okay. And what do you? I'm sure it's not obvious at all from your hesitancy in which you speak about Gen Med. How do you view I guess it sounds like PALCare is something that you've looked forward to, and it's felt like your experiences throughout your career has led you to that. And the decision for Gen Med sounds more of a work-life balance or a decision made on multiple different aspects.
Yeah.
How do you navigate that, and how do you? I guess how do you look at your time as far as Gen Med goes in the future when it's not necessarily your preferred specialty?
I think there's a lot of crossover. I think there's a lot of Gen Med patients that are PALCare patients. Anyone who has a progressive chronic condition is technically palliative care. So things like heart failure, COPD, those irreversible conditions, like they technically are palliative conditions. It's just that they're not end stage or end of life. So I think there's a lot of crossover, and I'm hoping that I can still utilise my palliative care skills as a Gen Med physician. It's certainly been challenging going back from having reasonable hours and minimal on-call, minimal weekends, to going back to quite long shifts and overtime and that sort of stuff. Yeah, it's not as easy now as it once was. Yeah. As you get older, it's hard.
As a consultant, though, your hours will be better, presumably?
Yeah, they should be, yeah.
So this is, I guess, going to be a two-part question for you because you have two different perspectives to offer on this. And we talked a little bit about this before I started recording. I'm curious about how you feel, how you see your role as a clinician towards patients, and your interactions with them, and I guess for you how that is different as a palliative care specialist versus a gen med physician.
I think it is different, but as I said, there's a bit of crossover. So I think gen med, they're generally more undifferentiated and complex, and so you're a bit more of a diagnostician, whereas on the pal care side, generally all that kind of medical stuff's sorted out, and you're trying to look at the bigger picture and try and really bring to the forefront patient wishes. And so it's more about the kind of encompassing the biopsychosocial as one picture rather than picking out the individual medical issues and trying to optimise them. So it is a bit of a difference, but as I said, I'm hoping to be able to kind of do both at once once I'm dual trained.
And what would you say is having some experience with other, and I guess interacting with other specialties as well, as far as your physician or palliative care, what do you wish that other specialties understood a bit better about either of those?
I guess definitely pal care. I wish people would I feel like there's so much bias with when patients are labelled as palliative, and palliative doesn't always mean someone's imminently dying. Sometimes palliative means they've got years to live, and so that doesn't mean just because they're known to the palliative care team or anything like that that they are any less deserving of having their medical issues investigated or managed in whatever way is most appropriate. So I wish that kind of bias was kept in check a little bit more than it probably is. I think from the gen med side of things, probably the gen med is so overrun and under-resourced that there are things that are kind of suboptimally managed, and that maybe if there was a bit more support from the other specialties, potentially that would be less so, yeah.
And do you mean other medical specialties or surgical as well?
Yeah, maybe both. Sometimes I feel like it's more rare for gen med to be looking after a surgical problem than it is for maybe something that could go under a subspecialty team, medical team. Yeah.
Okay. My 3 months with 5 weeks of annual leave of gen med that I did was certainly the hardest I've ever worked, I think. So I can attest to that, and I would not want to go back. And that was just the admitting jobs, not even the ward jobs. So I don't know which is better. Kind of felt like everyone hates you. The ED just wants to admit everyone. The ward team are like, why are you admitting this patient under us? I'm like, I'm sorry, I can't have it both ways.
Yeah, exactly right.
I was lucky to have you with me for those shifts, my evening shifts where you were coming on for the nights. And I think you saw me at my worst, just angry and grumpy all the time.
That's gen med. Everyone's angry and grumpy all the time.
And I guess now that you've done 6 months of ICU, you're also in the unique position of having been on both sides of that as well. What can you say in regards to your experiences with ICU from either perspective, and how it relates to the PAL care or gen med and how that could be done better?
I found my ICU time very challenging, but it was enjoyable mainly because of the support of the team that is present. I think the biggest thing I would love people to do is better goal care discussions. It's just so hard when you are coming to a patient you don't know, who's in extremis, who can't talk to you, if there is no documentation of what they kind of have wanted when they're more well and able to say it's really hard. And for like just doctors who don't know that person, don't know the whole story, to try and make really difficult decisions, potentially in the middle of the night where, next of kin's not readily available. It's, almost impossible to make the right decision by the patient. Yeah.
That sounds like a very pro ICU perspective. So you're saying ICU as a specialty is perfect and there's nothing
That's
we need
right.
to do better.
Exactly right.
That makes perfect sense to me. I think you said a few things about palliative care and how the perspective or the biases people have about palliative care. That was certainly something, I think for me when I did pal care, it certainly made me look at my own biases a bit. And even it felt pedantic at the time, but looking back on it and putting it into perspective, it certainly made me reassess it. I remember Ian Grant talking about he hated the word saying someone's palliative, as in using it as a noun or a verb. It was his pet peeve, which initially I was like, hang on, I thought like I'm using the word correctly, but which I think to palliate someone makes sense as a verb, but I think his issue was you don't say someone's intensive. And we often, when we do end of life care, we often say we're palliating someone, almost as if we're killing them. And so I can understand, even though it seems like being pedantic about certain words, it definitely has an impact on the way people perceive the patients. And
even how the patient perceives the patient, because language matters so much when we're communicating with patients.
And the other thing that when I first heard it was like, this is silly, we're doctors, was about handover and how palliative care physicians talk about the person first, and talk about, this is a 50-year-old grandfather of, maybe 50 is a bit young to be a grandfather, not necessarily.
Not necessarily, yes.
50-year-old Geelong football fanatic who, loves to do this and this, who's suffering from this. Puts it in a completely different perspective to this is a 50-year-old with COPD, and then 5 minutes later after talking about them being like, oh, they're a footy fan and they have family. Yeah, that's right.
It humanises again, doesn't it?
Yeah. What are your thoughts on that, having done some ICU as well, and the handovers are very different in ICU and compared to Gen Med as well?
Yeah, I think it depends. I think if you've got the time and it's in a controlled handover situation, bringing that humanity back into the handover is great. I think if you're handing over in a time critical situation, you probably you need to get the important bits of information across, and potentially, depending on the situation, maybe that the social stuff is not what needs to be handed over to the person running the Code Blue or anything like that. It certainly has its place, and when we do those kind of daily round or handover kind of situations, I think that's where its place is.
So I guess if we're at a med call or a Code Blue, that makes sense. But we have daily handovers in ICU. Do you think that could be done differently? And would that be better or worse, do you think, doing it in a person-centered way?
I think it could definitely have more social aspects added to it. I wonder whether it's maybe a little bit of a coping mechanism of some people to not have that social aspect and to dehumanise it a little bit for career longevity and those sorts of things. Yeah.
It's I ask this because it's definitely something of interest to me. And it came, I think, highlighted more for me working in a trauma centre where a lot of the time patients ended up being bed numbers, and it was really getting to me. And for me, I think as sad as it is, feeling like I provided care to a patient is more satisfying from a job point of view and a career point of view than just having done something to a number or a pathology. But I completely agree. When I thought about the fact that, hang on, we should be talking about the people rather than the bed numbers. and it was from the nursing staff as well. And I had the same thought as to they're the ones there in the bed space for 12 hours.
Mm.
And if it is a young trauma patient that has very minimal chances of recovery, that would be a hard, long 12 hours and a hard 12 hours.
Yeah.
So I just wonder like whether making it a person-centered thing makes it better or worse. I don't know the answer, and it will be interesting. But how do you think in palliative care, all your patients are going to die, 100% mortality, or close to.
Yeah.
How do you find, and most of the pal care people that I've met are the happiest and like most well-rounded people that I know.
Yeah.
How does that work then?
Yeah, I think that's the part that I really like about palliative care is that they actually acknowledge that. They acknowledge the part that it's really hard work. They do debriefs. They have strategies of kind of how to let go of the harder patients. They talk about the really challenging decision makings that can happen sometimes, and how to go about that, or the psychosocial kind of aspect that can really impact on the medical care, and how to navigate that, what resources are out there. And it happens in a really organic way sometimes, in that it can be quite informal, but then they also have formal once a week, sit down as a team, talk about what's been hard lately. And it's not like one person has to present each week. It's like whoever wants to presents. But then we talk about it as a whole group. So I really like that they kind of made the implicit explicit, because it really should be in all fields of medicine that we should be doing that. Yeah.
And is it a discussion about the decision making or just a debrief of the emotions?
Yeah, more about like the emotions of that decision making, how it made you feel, and what was the challenging part about it. More not necessarily what was it a right answer or a wrong decision or anything like that. It was it's more about how did you navigate that, and how did it make you feel, and did you feel supported, and how could you be more supported the next time something similar comes up.
Yeah. So less of a critique of decision making.
No critique whatsoever.
Yeah. Okay. Any thoughts on how that could be incorporated into the ICU that you've just been working in? We have MDMs, we have the long-term meetings. Any reflections on that, or how that could be improved on?
Yeah, I think the long patient stay discussions are often a good way for it seemed like a good way for the current treating consultant to get kind of backup from the other consultants about decisions for that week for that complex patient. I think you guys do it in an informal way as well, particularly the registrars seem to kind of debrief a bit about situations, and you've got the SR kind of support as well. I wonder if you could incorporate a more explicit kind of session maybe after one of the 11 o'clock meetings, on one of the other days that don't have other stuff after it, where you just have the doctor's day and you just talk about something that was difficult that week.
Yeah. And again, not about the medical side, but just of the how it makes you feel, or the support and okay.
And like the burden and the cognitive load or whatever it might be. Yeah.
But then you show weakness and you can't have that.
Yeah. Well, that's the problem, isn't it? We need to change that.
Okay. Again, I'm going to navigate this delicately as to not to compromise my career and future in this specialty, as to how I... it's tricky, isn't it? Because I guess you want to show that you can manage these situations, and it is a hard specialty, and you still have to do this for decades ahead, hopefully, if we're so fortunate to have a consultant job in this career.
Yeah, that's right.
That you're not sort of that you have a way to cope through it, and it has to be done with good faith with everyone, that it's not a judgment, it's a judgment-free zone, that you're not there to be like, why is this person so soft, why can't they manage this, that it's and that kind of has to come from the whole unit. And
Yeah.
But I think that it again, when I did Palcare, there was times when the consultant I was on with would talk about one of the patients that we were seeing or how they affected you, and or if they've died, you'd say some nice things about them or what your interactions with them, all of which I felt was too touchy-feely at the time. But it just felt like a completely different way of practicing medicine.
Yeah.
Going from ICU or anaesthetics at the time as well.
Yeah.
To this is all physiology and numbers, to that human element, and even feeling like less of a classical doctor, so to speak. And, and I remember when I did Palcare, there was like a couple of patients where after I'd finished all my ward duties, I'd just go sit with them and just chat with them. And that was never something that I would have done as a clinician before that in any other specialty. But it was rewarding and nice, and those more sort of decision making around your interaction with the patient rather than necessarily the medical side of things, which was often the challenges that I face as well, which I'm waffling. So I think we went a bit off topic because you said ICU was perfect. I think I find the ICU and Gen Med thing tricky, because often, a lot of the time, the patient when they're in ICU, the management from Gen Med don't have a lot of input. What could be done differently there? What can we learn from Gen Med? I think I learned a few things with me putting my foot in my mouth by talking about how busy I am in ICU, and you're like, I'm back in Gen Med now.
Yeah, that's right.
Yeah.
It's all relative though, isn't it? Like the complexity is different in ICU. So even if you've only got 12 or whatever it might be, like it can still be a heavy burden. I think, I
or I'm just soft.
No, I agree, and I kind of reflect on my time as a junior mid-reg and how I would often leave the ICU ones to last because I knew they were in a safe environment and I knew they were being cared for, and that you guys would raise problems if they were there, whereas all the other ones on the ward, I'm it. So, you kind of prioritise. And then by the time you get to ICU, well, the plan's already been acted for the day. So you're kind of like, well, we'll just do what ICU wants to do, like kind of thing. I think sometimes where Gemma's role probably is in ICU is to think about the more, like the zebras more than the horses, and to raise that as a possibility, because sometimes we kind of get focused on that it's this, and we kind of don't look at the differentials, and we're all guilty of that. I don't think it's any one specialty that does that.
Yeah.
And then also thinking about what's going to make the next days to weeks a bit smoother. And so if we kind of do some tests that are more subacute tests and get the results back while they're still in the acute phase, well, then maybe their whole admission will be a bit shorter. So kind of having that discharge planning part still right in the forefront, even from the get-go while they're still in ICU, is probably GenMed's role.
Yeah. Okay. I think with, and we might have alluded a little bit to this about other specialties in GenMed as well. Often when we have other specialties and patients of theirs in ICU, we're consulting them on a regular basis because there's specific treatment that needs to be done that we need their expertise for. And with GenMed, I guess a lot of what we do in ICU is what the GenMed team would do with the addition of organ support. But that discharge planning, as you say, that's not something we're terrible. Well, we're terrible at it.
You don't have to think about it. So
and my discharge planning is to the ward, not to
And you don't have to think about like optimizing their heart failure and things like that. You're as you say, supporting the organ in the acute phase, and then future planning for whether they need iron infusions and that sort of stuff is GenMed's role, I think.
So I guess you've had a bit of a navigated pathway through your career so far, going from research into medicine, and then different aspirations initially as well. What are you passionate about? What are you proud of in what you've achieved so far? and what's to come?
I don't think I've achieved anything particularly extravagant.
I was going to talk, like, as a disclaimer, talk about how you are too modest, and that how little you valued yourself in ICU when you provided so much more than you realise, and how much we valued having you.
I don't think that's true.
It's absolutely true, Ruby. There are so many times where I'm like, we're doing a ward round with you. I'm like, damn, she's so clever. I should have thought of this. I didn't think of this. And I've only worked with you a couple of times in ICU, and I was intimidated.
No, definitely not. I think what I've valued most throughout my career is being able to have kind of a mentor or almost pastoral kind of role. So I really, like, the more senior you get, I feel like the junior doctors turn to you. And having a personality where I struggle with the anxiety around medical decisions and bearing that on my shoulders, and not being able to switch off from work when I go home, and having lived through that, being able to help others who are experiencing similar things is really rewarding, I think. So I really like that part that's not patient care, if you know what I mean. Yeah.
Tell me more.
So I guess at first kind of started when I did the senior medical role the first time in 2020, and like doing education support, helping them through their exam period. It's a very stressful time for them, and then having to do the work on top and not feeling supported to get to your education and things like that. Being able to kind of talk them through that and develop strategies with them was really rewarding. And then I've just noticed that I guess people seem to a little bit gravitate towards me, and I don't know if it's just something I exude or just I don't know, but often people will bring up like that vulnerability, which, as you say, is not very common in the medical field. No one wants to feel like they're not performing with their colleagues. So I don't know what it is, but obviously people just kind of trust me to not bring it any further than that conversation, and hopefully it's helpful. Like they say, it's helpful, so that's always good to hear.
What a great quality for a palliative physician.
Yeah, hopefully.
Absolutely. And I think it also speaks to the respect people have for you. So when you feel like you're not of value, hopefully you reflect on the fact that other people value you so much, is reassurance that we do, and we have so much respect for what you provide. And you did have a lot of input in ICU and respect from the consultants all the way up from, well, I can't speak for the junior registrars and residents, but they're at that Dunning-Kruger worst part of the curve.
Yeah.
But I think all the SRs certainly did, and I'm sure the consultants did as well. So
Yeah, I just felt like a burden the whole time. So
absolutely not. I think if we had ethical concerns, and you would have been a perfect person to provide input and like a.
People do say I'm a bit of a moral compass. So,
So the stress and the anxiety that you talk about, where does it come from, do you think?
I don't know. It almost feels a little bit narcissistic.
Time for a therapy session.
Yeah, that's right. Exactly. Yeah, maybe it's a little bit narcissistic. I don't know that. I think I have so much impact on people's medical course through at the hospital that it's all on my.
Don't let out the secret that we don't do anything.
That's right. It's all on me. I think I have to keep reminding myself that it's not all on me. It's not just me looking after this person. It's a team, and that there's multiple kind of safety nets throughout all the disciplines, including allied health and nurses. Everyone picks up on different things, and I have to be really conscious about reminding myself of that, because my unconscious brain says it's me. It's all on me. I have to do everything.
Yeah. And clearly it's something other people that you see other people do, and they come to you for sort of, I guess, guidance on that.
Yeah. Yeah. I think It's most noticeable when you change, so when you step up from resident to registrar, or when you go from registrar to senior registrar. I think that seems to be, those transition points seem to be the ones that are most stressful. I think particularly when you go to registrar, because it feels like you are making some independent decisions, and maybe there isn't that as much oversight, and maybe you might make the wrong one, and so you kind of really start thinking through all the consequences of your decisions, and then you think about, oh, what if that happens, and then what if the next thing happens, and it snowballs a little bit. So I think that's those people are the people I've noticed that you can see it happening. You can see their mind kind of racing and thinking through all the decisions, and just helping them kind of step back and look at the whole picture is sometimes really helpful.
Yeah. And how did you come to that wisdom?
Because someone else did it for me. So I had a really good senior medical registrar when I was a junior medical registrar, and she was just great at trying to like reframe things and kind of put all the puzzle pieces together and make you realise it's not, this one little puzzle piece isn't going to make the whole picture. We need them all to put together before we see the picture. Yeah. Yeah.
And you mentioned about struggling to switch off at home when you get home from a shift, sorry.
Yeah.
And is that, again, the similar sort of anxiety of going through all the decisions that you made and trying to...
Yeah, or like, oh, God, I forgot to put that blood test in, or, I forgot to send that email, like just that kind of... Because sometimes the cognitive load is so much that the little things kind of slip by and you don't remember them until you're having your shower or whatever, trying to sleep at 2 a.m, that type of thing. So those kind of little things I find just pop up whether I want them to or not.
How do you manage it?
I guess if it's something important, I will make a note in my phone. If it's something that's not, like that someone might have picked up on or I can just deal with as time comes on, then I'll just let it go. I guess how I manage to kind of switch off in general, I do it through traditional escapism. So I read a lot of fiction and just try and escape that way.
Do you think it's a easier process for you now than it was, say, 5 years ago?
Yeah, definitely. I think with time, the more competent you feel, the less kind of you worry about the small things.
Perspective.
Yeah, exactly. Yeah.
And anything else that you have, is that, do you think it's just developed over the course of training and your career, or has it been something you've had to actively work on to improve the switching off?
Yeah, I've definitely had to work at it actively. I feel like most people would find the same thing that I've spoken to, that medicine just takes over your life. It creeps up on you and you don't realise it, and then all of a sudden it might be the only thing that you're doing. So particularly like during exam times, it just, even all your spare time is spent towards medicine. And so, I think it's definitely something that I've had to work actively towards of setting aside time that is completely non-medical time. Yeah.
And what's worked for you? What sort of strategies have helped you with that?
So I'll often schedule things, so appointments, or like I'll say to my family, we're going to go do this at this time, and then there's no choice. You've got something planned, so it can't creep in. Yeah.
What do you like to do outside of medicine? and second question to that will be, how do you balance it out?
Yeah. I like to do, so I'm a bit of a stress baker. So if I'm really stressed, which was like around exam time and that sort of stuff, I did a lot of baking, which my study group loved.
So ICU wasn't very stressful then, because I didn't get any baked goods.
So ICU was just so exhausting. I didn't have time or energy. The long shift killed me. But I like spending a lot of time with my family as well. I've got some young nephews and a niece, so I like spending time with them. reading, like a lot of reading, just hang out with my friends. Yeah.
And it sounds like just scheduling and making sure that you commit to family time outside of medicine is your way to balance that out, would you say?
Yeah, definitely. Yeah. And you have no choice. There's no doing stuff on the weekend. Yeah.
Or face the guilt of having let someone else down.
Yeah, that's right. Yeah.
It's always guilt is a great motivator, isn't it?
It is.
And we talked a little bit about sort of research and, you know, how you had interest in that, and throughout your career there's been certain aspects of it. Career-wise, are there any other aspirations that you have and want to achieve, or longer term, what do you envision when you're the director of healthcare for the state or the region?
I don't know about that. Yeah, I think maybe once I have a little bit more time, maybe I'll get back into research. I did like lab-based research originally, and so clinical research is very different. So I'm not sure if I'll do that or try and explore various other ways of doing research. But I maybe one day.
But career-wise, what do you see? As in, like, what's your ideal, career life look like?
I think my ideal would be 0.6 clinical, maybe 0.2 teaching. Yeah.
Through Deakin or just in like?
Deakin or physician training. Yeah.
And how do you? What does you talked a little bit about medicine taking over your life, sort of thing. How do you contextualize your work as part of your life? Like, what does it mean to you? What role does it play?
I think it became my identity, and I hated that. Yeah, and I still do. Yeah, I really want it to change. I think that like when you sit exams and you just lose a lot of your hobbies, and you spend all your day working and then all your night studying, and that's it. And then COVID also destroyed a bit of hobbies, I think, for everyone. So I'm working towards trying to find ways for it not to be my identity. I try really hard not to tell people that I'm a doctor. Yeah.
Why?
I don't want to talk about it outside of work. I don't want. I find what kind of medicine do you do? Oh, I'm a palliative doctor. Oh, that must be hard. I'm like, it's not. It's
lovely.
Yeah, that's right.
But then you seem like a psychopath.
Yeah, or they say, oh, you must be special. And it's like, no, I'm not. Yeah, I find that conversation is always really hard.
It was funny, when I was doing palcare, it was start of COVID, and I was going home early because there was nothing to do from a palcare point of view, and I'd cross the road in my scrubs and people would honk and wave and say, thank you for your service. I'm like, I'm about to go for a half day, so
that's right.
Felt so guilty.
Yeah.
So I'm curious as to, you feel like it's part of your identity. How, in regards to your outlook on life in general, how do you think your work has impacted that, or either your work or the patients that you've interacted with, particularly in palcare?
I would definitely say that I'm a pessimist at the moment. I think I don't know if it's like you see like kind of the worst sometimes in medicine in general, but also in palliative care. You see all the things that kind of go wrong. Rather than the kind of simple end-of-life care, you often see the really complex, really challenging. And so I think that does skew how you look at life. And certainly, I don't know, I suppose you see it in ICU too, where you see all the surgeries that go wrong and the complications and the people who have RS and don't survive, whereas... maybe they exist where they get ROSC and they don't even end up intubated or anything like that. And
we don't see them.
Yeah, exactly. We don't see those success stories kind of thing. And I think that really has impacted how I view life in general, and certainly my personal wishes towards my own care. Yeah.
Does it has it impacted on like your goals in life, or like what you want your life to look like? Not end of life necessarily, but just the story of life or whatever you want to call it.
Yeah. I certainly think I guess we all hope we won't get medical comorbidities, but
Yeah.
I think if I got multiple medical comorbidities, I would probably withdraw therapy a lot quicker than what I've seen in my patients. Yeah.
And I think I've asked this question badly. It was more sort of like when you envision the rest of your life, not in a health point of view, I guess, like just life in general, as the way your experiences in Palcare or as a physician impacted what the outlook that you have or what you want to achieve in life or relationships with family and others.
I think palliative care in particular has made me value more the time that you spend with your family and your loved ones in general. I think I don't know that it's impacted what I want from life. I think I've always kind of wanted the same thing, which is just to be happy and to kind of influence your little circle of people that you've got. Yeah. Yeah.
Yeah, I think again, doing Palcare was the first time I got to sit with people and just listen to them, and I found it fascinating what people talk about at the end, people that are about to die and what they talk about, and regardless of what they've done in life, it's always you reflect on the positives, and that kind of made me stop whining so much.
Yeah.
But it was lovely to see, people that are suffering and they know they're going to die. They're just sitting with their loved one and cracking jokes and reminiscing on the life that they've had, and it's quite beautiful, I think. And
yeah.
So, on that positive note, what does the future hold for you, and what are you looking forward to in the next little while?
Ooh.
I mean, not much clearly because you've just finished ICU. What could be better?
Yeah, that's right. That was the highlight.
Peak of your life.
Yeah, that's right. It's all downhill. I'm not sure. I'm taking it kind of as it comes. I've got some goals of trying to establish myself a bit more in Geelong, maybe buy a house and that sort of thing. But hoping just to remain here, get a little bit of a job, hopefully. Even if it's only
That'd be silly not to hire you.
Hopefully. And just continue spending time with my family.
And inspiring the next generation of medical students and doctors through,
Hopefully helping them stress less.
Well, there'll be, I'm sure, hopefully, my goal is, or hope is, that there'll be lots of med students that listen to this and get inspired to do a palliative ICU training pathway.
Hopefully.
Yeah. Thank you. Thanks for making the time. And it's, again, I want to highlight that it was a pleasure working with you. I think you were immensely helpful. I still remember the night shift that I did with you when I was doing my med time, and it would have been a lot harder for me and a lot more stressful if you weren't there. Because it was nice to have someone who I knew was like, this person knows medicine because I don't. I can do the organ supports. And it's been nice having you back in ICU and having the pleasure of working with you for the last 6 months.
Thanks, Vish. It was a pleasure to work with you too. Be supported by you.
Thanks, Ruby.
Thanks, Vish.